I want to welcome each of you to our monthly Government Affairs Forum. Thank you so much for taking time in your day to come and share your presence with us as we learn more about this important topic today that these gentlemen will share with us. Today I want to thank our presenting sponsors, Portland General Electric and Riverview Community Bank. Yes. I want to thank our education sponsor, which is the Gresham Barlow School District. And I'd like to recognize, thank you, Mr. Schwartz and company. I'd like to also recognize some of our elected officials that are here today. We have Mayor Ted Tosterud from City of Fairview. Welcome, Ted. Lori Stegman, City Councilor with Gresham. Welcome, Lori. We'd like to recognize our board members that are present with the Gresham Chamber of Commerce. We have Warner Allen, Jim Hathaway, Matt Miller, Sue Piazza, John Maloney, and Doreen Brower. So we have quite a number of our board members here, and thank you, board members, for being here today. We appreciate your support very much. My name is Bob McDonald. I currently serve as the Executive Director for the Chamber of Commerce. And it's my pleasure now to introduce Warner Allen. He is a board member. He is also the president of our Government Affairs Committee. And Warner will introduce our elected and special visitors that are here. Warner?
Thank you, Bob. Thanks, everybody, for attending. As you know, this is our healthcare forum. It seems like it's an appropriate topic for us to begin to address as we look at the new year and we look at a new Congress. And as someone once said, that when Congress is in session, no man's liberty or property is safe. I'm sure that wasn't me, but somebody said that. I'm pleased today to introduce our panel of experts. On my left is Tim Rash, who grew up in Seattle, but decided the Northwest further south was a better place to live. Apparently that, however, was after he had traveled around to Denver and other places that were more remote. In 2002, after launching with the mobile telephone industry, he worked with ADP and then moved to Tucson, found out what living in the desert was like, and after a year came back to the Northwest and began his career in employee benefits. He served as in a legislative capacity for the Portland Health Underwriters for almost 5 years now, becoming board president for 2014-15 this year. He's testified before the Oregon Health Authority, Oregon Health Fund Board on healthcare reform, regular participant with the Portland Business Journal, and has become an expert on the Affordable Care Act. And we welcome him back because he was here last year to address us also, and it was a very interesting time. To his right, I have Scott. And Scott Lofton is the Vice President of Sales and Account Services for Moda Health. He's responsible for new business acquisitions and retention processes for medical, dental, and pharmaceutical coverage, and administration services for Alaska, Oregon, Washington, and California. For those that don't know, Moda Health used to be ODS. He joined ODS/Moda in August of 1992 and has been with them in a variety of capacities as he's worked up his way up through the health industry. He's earned his Bachelor of Science degree in mathematics from Oregon State, Master's of Business Administration from George Fox. Then on my immediate right, I have Tom Holt, who comes to us with experience as the Director of Government Affairs for Cambia Health Solutions, parent company of Regence Blue Cross Blue Shield of Oregon. He's worked in the healthcare policy in Oregon for nearly 20 years now, and has over those years represented a wide range of healthcare players, individual providers, hospitals, pharmacies, pharmaceutical and biotech companies, etc. And last but certainly not least, Jeff Akers on my far right is the Director of Strategic Accounts, Labor and Trust, Occupational Health at Kaiser Permanente. Jeff has been in the employee benefits and insurance industry now for over 24 years. Interestingly, he previously was the Director of Sales and Account Services for Moda. So we've got him close hauled here. Jeff is currently responsible and leads 4 Kaiser Permanente lines of business, including strategic accounts for the Oregon Education or Educators Benefit Board, PERS, Public Employee Benefits Board, and public schools, Federal Employee Health Benefits Plan, Labor and Trust, multiple employee trusts and public and private sector unions, and occupational health and Kaiser on the job. Jeff holds a bachelor's degree in economics from Oregon State University, a bachelor's degree in business administration from Portland State. Apparently one degree was insufficient because he went on from there to get an executive management program from Stanford University's Graduate School of Business. Jeff's a registered health underwriter, and in addition to that, like me, he continues to want to work on his golf swing. So, with all of that, I'd like you to welcome our panel. So our format today is going to be them responding to questions, and I'm going to start off with a question to the panel to request that they explain to me and perhaps to others the interface between the Oregon Health Plan and the Affordable Care Act. Who would like to start that? Tom?
Sure. A key part of the Affordable Care Act was big incentives for states to expand their Medicaid programs. For the first couple of years, it's 100% federal money paying for the expansion population, the new enrollees in Medicaid. Oregon and many other states accepted that. And we've gone in the Oregon Health Plan from around 450,000 people on Medicaid to we're pushing 1 million now. That's a big, big expansion. Now what's going to start happening in the next year is that the federal share of that funding is going to start ratcheting back. And it'll drop to about 90% here in about 2 years. And that creates a budget challenge for the state, but one that we're well prepared for. We have a provider tax in place that draws down federal matching funds, federal tobacco settlement money, and some other funds that are being pulled together to continue to fund Medicaid. But it's a big deal. A lot of people who didn't have access to care now have access to care. This last year, we've seen the pent-up demand of untreated conditions, and that's starting to level itself out. And I'll let others chime in a little bit on that too.
Jeff, go ahead.
Okay, thank you. Well, first of all, you guys hear me? Make sure. I just want to say one thing that he didn't get to was I'm Gresham proud. So I'm a Gresham High grad, Mount Hood Community College grad alumni. I'm a member here, and I don't live too far from here, so I just want to make sure that I'm super proud to be here, just representing Gresham. So, from Kaiser Permanente's perspective, and I'll let him talk about the legislative and governmental and regulatory. We were trying to figure out how do we start getting these people into the system. So, at Kaiser Permanente, we have the insurance piece, but we also have the care delivery piece, and a lot of the Medicaid population had pent-up demand, as you just heard. So we were trying to figure out, well, how do we get these people in? A lot of them probably hadn't seen a physician in a while. They hadn't seen a dentist. So, I think what we were trying to do is figure out, with that pent-up demand, what are some tools to get them in? And one of the things we were looking at, not just get them in for things that are kind of at the forefront of their healthcare, but what might be happening from a population segmentation strategy perspective. So you have this wave of people coming in, and a lot of them are underprivileged. So, our perspective was we want to make sure we get them in for preventative maintenance, routine, get them paneled to a physician so they have access. What we see in this population is typically they don't have a primary care physician, so they kind of wander, the streets, if you will, trying to wait till the last minute to get care. So what we were really looking at is how do we reach out to this population, get them paneled, get them with a primary care physician, not just see their immediate needs, but what's their home life like. So we created a navigator program for Medicaid. So as we got these folks covered and in our system, what are kind of some of the cycles, social needs that they were looking at? So, again, not just the immediate care needs, but also what's happening in their home life. The stress, what are their families like, and just seeing what other kind of resources from the community could we get them in touch with. So we created kind of a navigation unit to really look at this Medicaid population, take care of their immediate needs, but also what might be happening again in their home lives with kind of this population health strategy.
Anything else?
Yeah, I don't think I
Sure.
do want that.
I do. So since this is near and dear to my heart. What's challenging when we look at the government versus the regulatory issues with Oregon Health Plan versus Affordable Care Act / Cover Oregon, who was here that made a big splash, that now is healthcare.gov. I get it. This is complicated. This is confusing. Just yesterday, I heard the story of a friend of mine who was told in December that she was not going to be able to renew. Let me see if I get the story right. She was not going to be able to renew on her subsidized plan with Cover Oregon, which was now becoming healthcare.gov because she didn't make enough money based on the income requirements for she and her daughters. It's a 2-household family. So she looked up the healthcare.gov, followed all the protocol that she was given, and healthcare.gov said, we can't enroll you in our system until we get proof that you had insurance through MODA at Cover Oregon. Well, to get the certificate of coverage, you have to be terminated first, which was going to happen December 31st. So she had to wait until her insurance ran out before she could apply for healthcare.gov with Oregon Health Plan for the insurance for she and her disabled daughter. She finally, after a 3.5-hour phone conversation, got enrolled yesterday. Last I checked, that was February. So she went a month and a week without coverage, waiting for the two bureaucratic systems to communicate. So my coaching to her is, I get it. This is frustrating. There's a lot of moving pieces and parts to this puzzle. We have new government restrictions and regulations because we lost Cover Oregon. We're now going with the feds. We still have small businesses who are looking for their small business tax credit. I don't know if we're going to talk about that later because that's a fun topic. But so my coaching to people is this just requires patience from all of us. The customer care rep that's on the other end of the phone line who truly does want to help you is trying to evoke some patience because their systems are tied up. But what I hope to say, and through all of this, which Tom and Jeff kind of alluded to, is I think there's just some patience I think that we can all give into the system that yes, there are lots of government regulations involved. Why, do you qualify for a subsidy? Or should you be an Oregon Health Plan member or not? But it's tough, and I think no matter where you're at in the spectrum of employer-paid insurance, individual-paid insurance, are you on a subsidized plan or a government Medicaid? There's patience I think that all of us could benefit from just trying to breathe and kind of let the system play out for us.
So thank you. Second question I've got is, would you all comment a little bit about what you've seen already in the increased population seeking care, and how are we facing that challenge from a provider standpoint and from an insurance standpoint? Who'd like to address that?
I can start talking about that if you like.
Thanks.
Yeah, I can't comment probably from a provider. Sorry, can't. I'll try. You want me to? I can stand up. There you go. Because I think you said it would be better to comment from here. And let me just address one thing. Since Jeff did mention that he's a high school grad from here, we actually went to high school at the same time, though he was older than I was. So we both graduated. We could get the paperwork out if you want to go through that. But I'm the only one who still lives in the city of Gresham, so at least you don't do that either. So I graduated from here and I still live here too. But thank you. So with the question around what we've seen from an increased care, the perspective I would lead with from a MODA standpoint, because we picked up a large portion of the individual enrollment from the Cover Oregon. There's a lot of words we could use around Cover Oregon, but we'll just try to refrain and call it Cover Oregon today. From 2014, we definitely saw an increased need, an increased care. I mean, predictions were that our actuaries set rates and the realities of today, even when we had to set rates for 2014, we were doing it 9 months prior in 2013. And then you actually enroll 80,000 new people into the system that we saw, and things don't always happen as they seem, especially with a lot of the changes that happened along the way, because 9 months is a long time, and things happen to change all of the assumptions we make. So yeah, we saw a definite increase in the utilization of what we had seen passed from individuals, because these people really didn't have care. In some cases, they had gone years, months, any of these time frames without care or having coverage, and they were new to the system. Our customer service department, if you had our coverage, I'm sorry, because we had a lot of wait times. They were very long last year, and part of it was because these people that were coming in, making these phone calls, didn't know how to make an appointment with a provider. We had people on the phone for 10, 20 minutes just telling them how to actually make an appointment with a provider to get in to be seen, because they hadn't seen a doctor. Their only access was through the emergency room. So there was certainly, from our side, well, I don't know if I'd call it an explosion, but a type of explosion of care for the people that we saw, with a definite increase in that utilization. And that's going to, over time, I do believe that will settle down as more people get care, unless we see some things come along from the government that then retracts the availability of coverage, so then people end up without coverage again, because there will be some level setting. And I think Dorian was saying earlier, it would be good to hear from the provider side. Maybe Jeff can comment on that too, because we have seen with the increases in the Medicaid population, Tom mentioned how many more people are in Medicaid. We are one of the Medicaid carriers for 12 Eastern Oregon counties, and those are very rural counties too. And what we've seen is a definite shift from emergency room care to provider care too. So the hospitals are even dealing with a new, different revenue model, because they were getting so much of the revenue from the emergency rooms, and now they're getting it from having to get it from other sources as well. So there's a shift on the provider side. Like I said, Jeff's organization may be better able to handle those questions, but we saw a definite influx of people needing care that hadn't had care before, and just overall access was new, and there was the ability for the system, I believe, from a provider side to handle that, but it was certainly a lot more than what we expected.
Jeff, did you want to address the provider side?
Sure. Do you want this one back?
Yeah, I think, again, as I alluded to earlier, just that pent-up demand, and a lot of people come in. I think, the immediate needs was just at the forefront, taking care of what might their immediate needs be. But I think as we looked at this population, there was a lot of care gaps. And what I mean by that, they didn't have their cancer screenings up to date. They, lots of incidents of chronic conditions that were out of control. So, I think from an influx into a system of care, the greatest part was identifying, again, getting those immediate needs taken care of this population, but also looking at, what are the care gaps? So making sure that they're up to date on flu shots and diabetic screenings and your cancer care screenings. And then look at, what chronic conditions might they have. And that opens up a whole another host of, how do you educate these folks? And you can imagine somebody who might not have had coverage, just the epidemic of obesity, just in the population, and diabetes. You get a certain percent of these folks in, and it's unmanaged, so unmanaged diabetes. So how do you get them on the right RX, the right prescriptions, and then teach them to have adherence to the RX, because they're not used to having prescription drug coverage. And as Scott alluded to, unfortunately, the system of care for them was really, when it got bad enough, they showed up in the emergency room. So how do you teach them to use a system of care? Use online tools, and if they have the capability to email a doctor, call a physician, and just get into a primary care, patient-centered medical home, and be part of a system of care that systemically treats them, over a spectrum of issues that they might have, and get them medically stabilized. I think that was really the first thing. And I think the second thing you got to look at is, not just with this population, but with all of us, is how do you start instilling, as we talk about healthcare reform, how do you start talking about individual reform? And what I mean by that is, how do you make individuals accountable for their healthcare? So, do they exercise? Are they eating right? Are they getting sleep? Are they managing their stress? So, as you can imagine, this Medicaid population, you have a whole host of problems of just identifying, from a population standpoint, how do you start identifying some root causes and making sure that, you know, they're in a system of care that keeps them, you know, healthy, adhering to medications, keeps chronic conditions under control. So I think at Kaiser Permanente, you know, that's one of the things that we're very cognizant of in looking at this population.
And just add to that a little bit on looking at from a perspective of last year being a catalyst and what we see as a turn toward a much more retail experience for healthcare. You know, healthcare is full of friction, incredibly opaque in terms of decision making and pricing. And what we saw last year, for all its faults and failures, Cover Oregon put about 100,000 or so people through a decision process of actually making a choice and seeing what their choices are and how they purchase health care. And then we're seeing in the larger group market a lot of interest in private exchanges where employers are wanting to drive the decision down to an employee level instead of being kind of the company town attitude of, well, we're going to go pick a plan for you and that is your plan, period, to giving employees individual choices about what they can do. Now, for us, it means looking for ways to enable that and providing decision tools that are practical for the individual. So, you know, we have transparency tools, for example, that, you know, if I need to get a rotator cuff fixed, I can go and look and see not just what each individual procedure is within that, and I'm not going to know what all those are as a layman. What I want to know is what's it really going to cost overall? How long is the journey going to be in getting that fixed and recovered? And we put that information in people's hands, and what we see is that at least for things that are planned, when people have good information, it makes a real difference on what choices they make for what kind of treatments they get and where they get them. Because there can be very, very different experiences in terms of their commitment as well as out of their pocketbook, which is what everybody wants to know at the end of the day and when they encounter healthcare. Am I going to get better? How long is it going to take? And what's it going to cost me? That's what people want to know.
So shifting the discussion a little bit about what's it going to cost from what's it going to cost me to what's it going to cost my employer, especially the small employees, could we address what you see on the horizon for the rest of this year and most importantly in 2016?
I think to continue Tom's discussion, there are some good things that the Affordable Care Act has brought to mainstream, to the public, to the discussion. And I don't want to, I think we should kind of dive in a little bit more that we're now seeing at the table that we've got a member, as Jeff discussed, where we're starting to talk about consequences, which could be positive and negative. Are you taking an over-the-counter or a prescription medication because you're a type 1 diabetic? Well, are you doing anything with your diet and exercise to manage that, to maybe reduce what you're paying as a consumer out of pocket, because our drug costs are going up. They're going up for everybody, not just the member, but the insurance companies as too. So now we have some three legs in this three-legged race where we have the member, we have the carrier, and we have the physician, and we have groups of folks working together to reduce the costs for all of us. So all three carriers that are represented here on this panel are doing a fantastic job on putting this out to the mainstream. We're not just going to throw the headache at the doctor. We're not just going to make this an employer choice because your rates are going up double digits every year. And well, we just think that we'll throw consumerism back at the employee to say that you used to have no deductible. Well, now you have a big deductible, and all these high-end prescription drug costs are now going to cost you because our copays went up. But I really like the communication that's going out in the marketplace that we're all in this together. Providers are looking at running their business, and more importantly, I think as kind of before some of the ramifications of the Affordable Care Act fit, small businesses, and a lot of us here in the room that operate small businesses, we're seeing this as a necessary evil for our people. Do we have to provide health insurance to compete in today's marketplace? Or are we just going to pay higher salaries? Or am I just going to pay a payroll bonus and I'm out of the healthcare and you go out and get whatever healthcare if you want. If you want to have 3 employees, 2 with MOTA, 1 with Kaiser, you have that right where you can do that now because pre-existing condition clauses aren't the issue that they used to be. But one of the things that we're seeing from the carriers, especially represented on this panel, are what I call kind of strengthening and giving us more intelligent panels of providers where the insurance company can manage that process a little better, because ultimately that comes to a better rate and a better service to me. So we're seeing these PPO networks of choices of doctors where we're now kind of showing a smaller limit of, instead of being able to go to any doctor in the state, if I live here in the Portland metro area, I'm going to be limited based on some of these community care networks and smaller HMO panels where I can go for care because it's easier for the health plan to manage outcomes. Tom talked about transparency. It's easier if you wanted to look for a knee scope, or you have a child that has a chronic issue, that I'm going to do a search to see who's got better outcomes, who's got healthier outcomes, not just because it might be better out of pocket for me, but it's going to be easier managed within our family, within our health plan, the whole deal. So we are seeing a big improvement, which is kind of also now showing us lesser of a burden on the employer to have to bear the cost of all of these increases. Things are just getting a little tighter, they're getting a little smarter, and I think we're just at the beginning of where this can take us.
Really? Okay.
Yeah, we all get asked this all the time, is the Affordable Care Act going to, control costs? Is it going to reduce my premiums? And, this is my opinion, it's not. I mean, this is just scratching the surface. I mean, there's so much more to what the Affordable Care Act brought into when it was signed into federal law in 2010. I mean, if you take a step back and kind of look at the endemic problem in healthcare, it's not really about reform. All ACA did was, that's really a healthcare insurance financing problem addresser. What really has to happen is there's two pieces to this, and I think what prompted me to say this is, listening to Tim, is there's two other pieces that really have to happen before we see healthcare transformation. So that's, when is the cost trend going to go down? When is affordability going to be more reasonable? And I think the two things are, one, we just kind of alluded to it, it's that individual accountability reform, and we can talk about that in a minute. And the second thing is really, and this is I think uncomfortable for a lot of us to talk about, but it's payment reform. It's around the way providers deliver health care. So those are really kind of the triangle, that's the three-legged stool, right? I mean, it's the health insurance financing reform that we're seeing right now with the Affordable Care Act. And then I think what's really kind of going to be the crux of the next wave is, how do we get us all to be accountable? And I told Jesse I was going to use him as an example because he's a Kaiser member, but he's giving me the EL, so I'll use myself. And I'm a great example. So I'm almost 50-something, and so as I think about it, do I get 150 minutes of exercise a week? No. Do I get the right amount of sleep? No. I'm probably, as I say this, I'm looking at the guys. I'm probably a lot like you guys, in the sense that, am I up to date on my care gaps, right? Nobody over 50 should die of metastatic colon cancer, right? With colonoscopies, colorectal screenings, fit tests. I mean, it just should not happen. But you know what? We don't go in. We don't get our prostate exams. We don't get our colorectal screenings. And it's readily available. I don't get a flu shot. So, there's this individual accountability. That's what's going to control healthcare costs. So, it's incumbent upon ourselves, really to do it. And is it going to happen? Not with 65% of Americans obese, with a BMI over 30%, not with diabetes as prevalent as it is. I mean, that's the freight train that we're looking at. So, and it's kind of short-sighted to sit here and talk about the Affordable Care Act. It's really, what's causing all of this? So that's the second one. The third one that I alluded to is really, it's healthcare payment reform. So it's how we incentivize practitioners and providers, right? Right now, we incentivize them on volume. Does that make a lot of sense? Probably not. What I think the Affordable Care Act is getting us to do from a provider standpoint is really talking about quality. Making sure that we hold our patients, if I'm a physician, holding our patients accountable, making sure they're getting their care gaps, making sure their diabetes is under control, making sure they're adhering to their RX. Talking to them about the stressors in their lives, and getting them, to other care delivery systems in the community. It's not just about a provider, and getting them in a medical home. So until we start, addressing those problems about how we incentivize provider quality and hospital quality, we'll never get to the true crux of the problem and bend that cost curve.
Just add to that a little bit. I totally agree about population health. We could have the most elegant, most successful payment reform, insurance reform, all that infrastructure stuff. And we will maybe have touched 25 to 30% of the healthcare dollar. The big win is improvement of population health and getting people more engaged. But what we see today in terms of the kind of delivery change is a lot of interest, I think, on all sides, payers and providers, in trying to figure out ways to really truly do things differently so that the incentives are better to help focus people on taking care of themselves. We have an arrangement here in your backyard with a dentist where, basically it's a population health management model. And, as was alluded to, that's a closed network product advertised as such. But the bargain there is that if the provider knows that they have an identified population that's going to come to them, then they can step out and take some risk in being accountable for quality and outcomes of that group of patients. We can't expect the same thing of a provider if it's kind of random PPO selection, go everywhere you want. And there's a tension there. The demand for the PPO is not going away anytime soon. It's going to be there for a long time, and that's what a lot of our customers want. But there are also customers who are ready and anxious to engage in these new, frankly, kind of experimental models in the marketplace. And it's exciting to see providers being willing to engage in that, and seeing employers say, yeah, we want to do this different. We can't tolerate the old way anymore. We're ready to change.
So when you look at these new models, is there anything in the insurance market that provides any incentive or opportunities for employers to fulfill the requirements of the health insurance industry's, the ACA, and still engage in these kinds of new models? And if not, what's it going to take?
Well, Kaiser has a program that they've had in the marketplace for a while. It kind of piggybacks on both what Tom and Jeff are talking about, where Kaiser has a very unique model where they control everything within the circle. And one of the things that they've done is they partnered with a PPO carrier outside of Kaiser for that employer that might have the employee that doesn't want to have the Kaiser ID card. And you've been able to, as a broker, going to the employees, recommending that if you don't like option A, there's option B, but option B is going to cost you. The control method is based on the HMO platform that Kaiser has. We're going to provide you X. If you are that individual that isn't a big fan of having everything controlled and you want to seek care outside of Kaiser, here's this. And in a lot of cases, the employee, the member of the family, has to pay different. And what we're seeing the cost of that, it's called added choice, and what we're seeing is the cost of that added choice program ballooning exponentially because it costs Kaiser a lot of money to manage that relationship outside of their control. So basically what we're doing is we're throwing that back to the member to say, if you still want that option as an employee at this firm, it's now just going to cost you more exponentially than the program within Kaiser. So for the clients of mine that we did that, most of my employees now, within probably the past 3 to 5 years, have completely migrated off that added choice PPO format because somewhere along the line they dipped their toes in the water and they walked in the door at Kaiser and they said, wow, people here are kind of nice. And the service here isn't as bad as my grandma's babysitter down the street that told me so-and-so's uncle's dog's watcher died 20 years ago. Well, that would happen probably anywhere. So what we're seeing through consumerism is, and maybe I will give myself a raise, a take-home, increase in my take-home pay. Because now, maybe for my family, I'm not so bent out of shape that I have to go see the doctor down the street because no matter what, I don't want Kaiser. And they're starting to make a shift, and we're starting to see this in consumerism, where people are seeing that I can focus first on my own care and focus first on my own cost of care and be accountable for all of that, and using within these systems are fine. MODA has got a very similar program. I alluded to it earlier with these community care, these smaller networks where employees wanted access to, I want all of these hospitals, I want access to all of this stuff. Well, if you want to choose that plan and your employer wants this narrower network plan because it costs us less money as an employer, as employees, we're starting to see kind of the shifts where people are starting to look at that through education, that this is good stuff, that I can be and I should be and I will be held more accountable for my own care. So just kind of seeing the shift in the marketplace through employees, they're just kind of that at first it was, I don't trust the system and I'll pay more for it, to, wow, look at all that money that I might have wasted on stuff that I didn't use in the first place. Where now that I see how this is working and I see kind of how transparency is impacting us as members through the groups I manage, it's kind of a beautiful thing.
I would only probably add the fact that I think you're seeing, you used to see the full spectrum where you had Kaiser that had a certain delivery model and they started moving towards choice, and we and other carriers pretty much had a network that had almost everybody in it. And I believe in the future that we're going to see this move towards the middle, but employers that want to could still have the choice of the full network or a very limited network. So that's what I believe the future will bring. And if healthcare reform goes forward and small group moves on to the exchanges and healthcare reform, you're going to see that even come to the next revolution, where if the employer gives it over to each individual employee to not only choose maybe from a panel perspective, even a carrier with a different panel perspective too. So the choice model is definitely moving in that direction for small employers, and if healthcare reform is moving forward and it starts moving into small group, which is the next segment we're going to see, you'll definitely see more choice involved there. The next step to that, because Tim alluded to this narrower network piece, is the provider risk models. That's really started with the expansion. I'll tie back in the expansion of the Medicaid population in the state. Has really, they're pushing payment reform, getting the providers involved from a risk standpoint. So we're moving that narrow network piece maybe more towards an actual payment reform piece that we've already talked about too, so you can incorporate both pieces. So yeah, across the spectrum, that's where we're going to see more of a focus as we move forward, is more choice, payment reform from the provider side. But if you move it down to the individual employee, then you can start to see all that choice open up, which is what the original intent was, to bring it down to an employer of 5. Let them buy full choice, let them move into this exchange model where they can have 5 different carriers, or they can have the same carrier with multiple networks, or they can have choose not to buy the coverage too, which moves us into a whole other area we can talk about when their payment reform from the employer side comes in with pay or play, or as they move this model from individual to small group, and small group expands, which is a whole other topic too.
So anybody out there want to ask a question?
Thank you. I'm Cosmo Salabello, and being in the reality of what's going on, especially in Washington, there's some political football aspect to ACA. Talk of changes coming up in this Congress. If that happens, are there any contingency plans going on with the carriers? And if so, what's on your wish list?
Wow, okay. Yeah. Tim's probably the expert here because he's definitely involved in the legislative side, but maybe I'll start off this time instead of following up. So 2 big things are coming up, because you talked about changes in legislation. Right now, obviously, Republicans are in a lot more control in Washington, and they're, I think it's this week actually, are starting to review House bills that will potentially come out to try to repeal healthcare reform, which we all kind of expected. Where that goes, who knows, because we're at the beginning of it. And then Supreme Court's going to hear in March, I believe it comes on the docket March 4th, who knows when it actually come out, they'll actually review the whole subsidy piece of non-state-based exchanges and whether or not the subsidy is actually legal. So there's going to be legal legislative challenges to healthcare reform over the next few months. So I think what your question really was, okay, what happens if it completely gets blown up, and what happens? I, from our perspective as a company, we had to embrace healthcare reform and say, we can't just sit on the sidelines and see what's going to happen 2 years down the road, because the reality is we're already 2 years into it, a year and a half into it, and it's made big changes. So I don't think they can just say that it's completely unraveled and go back to the way it was before, because everybody's moved to those plans and it's going to take them a while to get off that. So my estimation would be they'd have to come out with some kind of an alternative, at least in the middle somewhere, that they might have to agree that some of the things in place work. We've talked about it. Choice is a better thing. Payment reform is a better thing. I think Jeff even alluded to it, that it's healthcare reform, but really what we need is transformation on some of these pieces. They've tried to talk about some of it, but it'll definitely get addressed in the next few months, either from the legislative side, which may not go somewhere, or and the Supreme Court's going to hear some of it, which would certainly change the basis around subsidies. That this enrollment, 100,000 new individuals in Oregon, the majority of those were getting a subsidy, so their premium levels were very low. They can't have that subsidy. What's that going to mean for the marketplace too? So that's definitely going to be reviewed in the next few months.
I'll chime in on that one. That's kind of my world in government affairs. There's certainly parts of the ACA that even conflict with each other because it didn't go through a normal legislative process. Normally you have a bill goes through the House, goes through the Senate, and there's a reconciliation of the two in a conference, what they call a conference committee. And that never happened. So yeah, there's stuff in the ACA that needs fixing, and privately ever since it passed, both Democrats and Republicans have been building lists and saying, yeah, we see this probably needs to be fixed. What we will see this year, as we've seen the last couple of years, is what I kind of call press release bills that the Republicans saying, let's repeal the ACA. Well, there's a small matter. The president has a veto pen, and it takes a 2/3 majority to override that. That is not going to happen. Could the Supreme Court in the Burwell case rule that if you're not a state-based exchange, that there are no subsidies attached? Yes, there's a strong possibility. And behind the scenes, the federal government has been preparing for that possibility. That's why Cover Oregon, or whatever it's now going to be named when the legislature finishes acting in the next couple of weeks, is officially a hybrid model. It's state-based, but using the federal technology just as a contractor. They didn't want to become a federal exchange. Neither the state nor the feds wanted them to, because of the uncertainty of the Supreme Court case. Now, some things that could happen this year, we're hearing there's a very strong possibility that the deadline for the expansion of the small group marketplace could get pushed back, both for technical and policy reasons. There's a big rate shock for employers between 51 and 100 employees involved there, and that's what's giving some people pause, but there's also just flat technical issues, and nobody wants to relive last year on a technical front in implementing small group exchanges. So those are some things that I think are coming. There's some other low-hanging fruit, but more kind of in the weeds of the mechanics of how it works than things that really affect the market. For us as a carrier, none of this really changes what we do. We're moving forward with a reformist mindset that things have to change. We want to be a catalyst to changing them productively. Will we have to make adjustments if something happens with Burwell? Sure, so will everybody. But that's not something we can build our business around. We just have to stay close to it and do our best to plan for it. Contingencies, but not get carried away with going down rabbit trails on contingencies when, people like you have to deal with the real world of, what's my choice to buy a plan for my employees or for me today or tomorrow? What do I need to know? And that's where our focus is.
So based on the fact I live in the weeds, let's jump in for just a minute. One of the bills, in fact, I'll be in Washington, D.C. on February 21st. We have an annual Health Underwriter lobbying event, and we'll be meeting with all of our state elected officials, Merkley included. He actually showed up last year. It was kind of cool. So one of the things that we're watching very closely is one of these laws that came about within the Affordable Care Act about what does a full-time employee mean? What is a full-time equivalent? what is full-time versus part-time, and now this new thing called variable hour, and are you hiring people for variable hour, or what if they become part-time, and if I had provided insurance, do I have to provide insurance anymore? What if they worked over 30 hours, and if it's a Tuesday versus a month that ends in a Y, and all that fun stuff. So one of the things that we're watching very closely is our House in DC did pass a bill that is going to put the full-time equivalent back to what the rest of us have all grown up to equal full-time at 40 hours, which I think is a cool thing because there were a lot of industries that had to make a business adjustment on if I have a full-time employee and I have over 100 lives and I have to provide insurance now or face a penalty. So hundreds of thousands of workers across this landscape in this industry, which of golf courses and restaurant and lodging and manufacturing and you name it, all got their hours slashed effective January 1st, 2015. Basically what that meant is because the employer couldn't either afford the A penalty, the $2,000 per person, or about the $400 or so per month that they thought health insurance was going to cost them if they had a large group of employees that they couldn't pay for. So one of the things that we're watching very closely is could we all strap on our big boy pants and consider a full-time employee to be 40 hours? That helps all of us. It puts money back in the worker's pocket. So if they weren't working 40 hours, maybe they're working 36 or 37 hours, because let's be real, employers are still going to have to make that business decision. But now I'm making more money that I can go out and see if I can qualify for a subsidy. Because right now, one of the things that's going to impact a lot of businesses are unemployment claims. Here in Oregon, if you were working 40 hours and you got your hours cut back to 29 and a half, so you didn't have to be part of that pay or play mandate, you can file an unemployment claim. And I don't think a lot of businesses thought that one thing, and again, I'm no attorney, nor do I want to play one on TV, is this funny word called ERISA, which has to do with rights of employees being violated, that if you did work in excess of 30 hours, and you would have normally been qualified for health insurance, in order to disband that premise that penalties are expensive, I'm going to cut my employees back. Well, that's a very large issue with ERISA, and I think we're going to start seeing some companies being hit with some possible fines here this year, because that's kind of a just unequivocal consequence that this law brought out was businesses had to make changes. So I'm hoping that as our Senate is looking at this, and Tom kind of alluded to this a couple minutes ago, is let's look at that bill and let's pass it and let's put everybody back on the same wavelength that a full-time employee is 40 hours. And then let's kind of regroup and see what that means nationwide. So that's one of the things that our Health Underwriters Association is watching. We're very involved in it. We've contributed a lot of money to the campaign, and we hope that that's one of these things that comes from this, is we think that maybe some of these things that we passed in this bill, because we didn't look at it as effectively and efficiently as we should, is let's put everybody back to 40 hours, regroup, retool, and see what that means. So as we watch that this year with our Republican elected Senate now, we'll see what happens. The downside is that we have a very badly bruised Democratic president who's watching as his bill that became his law kind of gets retooled. He's kind of taken some of these things personally, so we'll have to see which things he's willing to look at and which things he's not. But that's one thing, and I'll report back to you guys as we get updates on it, because I think it's going to be very exciting. It's going to help a lot of probably our employees, a lot of people that we know personally, kind of get back on their feet with their jobs, kind of get things back to normal, and see if we can fix maybe that little piece of the weeds.
Give my notes. So when Scott and I used to work together, we used to battle for see who had the most airtime. So I thought I'd better come up. So from an integrated healthcare delivery perspective, not the insurance side, I would say whatever happens with ACA, I think most providers, and I look at Doreen and her organization, I think we stay the course. I mean, there was spirit and intent in the Affordable Care Act that really is a guidepost. And I'm thinking it's really about affordable, high quality, accessible healthcare. So, from that standpoint, I think from a care delivery perspective, there's a guidepost, there's a framework there that we build off of. And I'm thinking specifically around, a great example. You asked earlier about what are tools or what are some good examples. Medicare actually provides a great frame post for us. They've gone to, payment reform, pay for productivity and output. they've also, the quality pieces there. If you've heard 5-star, you see the advertisements on TV. That's a HEDIS, an NCQA measure. So I think, that guidepost is there for us from a care delivery perspective. And I think there's things there that we can work on. I mean, I think if you take this conversation as a whole and you tie it into what do we do from a care delivery perspective, not from the financing and the insurance piece, we got to get people into medical homes. We have to get them tools. You've heard us all talk about what do those tools look like. So, as you're out looking for, where you're going to get your care coverage, you want to make sure that they have an electronic medical record. So that weeds out waste and duplicative lab tests from the system. So you got to see if there's an electronic medical record. And you got to look at the quality perspective. Do the docs, are they worried about my prevention and my wellness? So, I mean, at the core of it, does it make sense that we gain from treating 6 patients, or does it really gain from a care delivery perspective? Do we get out in front of that and make sure that wellness prevention is the cornerstone of healthcare delivery?
Next.
You've all indicated that the biggest growth as a result of ACA and enrollment has been Medicaid and people who are receiving subsidies for their insurance or cost for medical care reimbursement. Given that most of us who have employees that aren't being subsidized are paying our own bills, I'm curious, what's going to happen next year as the federal subsidies start to peel back to the premium costs for those of us who aren't involved in these subsidized programs?
One of the
we all came here to find out.
Okay, we're going to jump back in the weeds for another minute. So, one of the things that on the small group side here in Oregon that we were all kind of considering were 2 employees to 99 employees, highly technical term called rate banding, where you could take the rate of your 20-something individual, and correct me if I'm wrong on this, and then you could take your pre-Medicare age individual, and you could have a 5-to-1 split between the low end of the rate to the high end of the rate as you age. What the Affordable Care Act did is they sandwiched it. So another thing that we're watching, another bill that we're trying to get passed in Washington, D.C., is can we go back to the 5-to-1? Because what it did is it elevated everybody's costs, because now instead of having a matrix of 5-to-1, I'm 3-to-1. And so within kind of the small employer spectrum, this is really the biggest impact of your rates for you and your employee, is that piece of it. It's not the overall health of your employees, because you can't be impacted by if one of your employees gets stricken with cancer or a heart attack. That claim rate on your small is not going to impact you. The pools from the carriers, they've done just a magnificent job keeping those healthy. So each one of our carriers here represented at the panel have kind of their CHI, their small employer health insurance pool here in the state of Oregon, to kind of absorb those claims from the 3-person print shop. If one of those people gets a claim, well, the overall pool will help kind of absolve that and protect you as a small business. And they've all done fantastic jobs. We talked about the narrow markets, the transparency, we talked about the communication education piece. All of those things are extremely valuable in kind of controlling that cost. So I don't think subsidies are going to be the biggest issue if those sunset, or we have a Supreme Court that says we need to retool kind of how we're going to reimburse state-based exchanges versus federally based exchanges. The overall issue for small businesses is just going to be the continued added cost of when we look at all of these components. One of the things that we haven't, even we talked a little bit about, is the cost of that provider and the overall business expense with things like tort reform and liability coverage and wrongful suits that raise the cost of these small providers a lot, which then go back to negotiating contracts with the carriers. Those are going to be, I think, weighted a lot more, and I'll let these guys chime in if they agree or disagree. But I think as a small business owner myself, I'm more concerned about what's this system doing and the overall creativity for the health insurance plans that are available to me as a small business owner in Oregon. And I'm looking at that farther and way deeper than I ever did before. And subsidies aren't going to be what drive up my costs.
Anyone else? More? Okay,
We get that on record?
we did. We'll print it up and publish it.
Good morning, I'm Ron Pomp with Transamerica Financial, and what my clients are seeing out here is their hours being cut. Most of my family's on double incomes, and at least one part of the family has been cut back to 29 hours. It is impacting them, and I've got family members that, to my chagrin, that are being subsidized into this system. And I want to know what your percentage of enrollment is of young and healthy or adults that aren't on the Medicaid system, because it appears to most of us out here that 90% of your enrollment is Medicaid or unfunded that are high risk, high maintenance, and the cost is going to come back on, where's it going to go when the subsidized runs out? I'm under Kaiser, I have a Kaiser plan, and I'm just waiting for my plan to go up, because I've seen a lot of my clients that are already paying for their pre-65 coverage. I've already seen that get hit very hard. One more. When the subsidized runs out, when the federal money runs out, what's going to fund this?
You can clean up, because, yeah, I can only speak really from MODA's perspective on, we do have a large piece of subsidized enrollment through individual. We have a greater population of Medicaid enrollment than we had before. We also have a lot of 51 to 99 employees and small group employees and large employers, and right now all those pieces are segmented. The Medicaid population has to live on its own, and whether it's going to get cutbacks from the federal side or not. The individual side has to live on its own. Everything we do on that side is monitored by the state. We have a filing that goes in place, and they scrutinize every piece of it. Our small employers, the only thing I would add, just to tie back into what Tim was saying earlier too, is from the small employer side, the only benefit in Oregon so far is that most of the reforms that were in place, Oregon saw a few years ago, where all of pretty standardized plan designs, pretty standardized, everybody has to be covered, there's no pre-existing conditions, those things were in place. What we are seeing is the individual population is getting more expensive, and you used to be able to buy an individual policy if you were a healthy person, 25-year-old, because you could go through health underwriting much cheaper than if you were going to cover it through a group, because we couldn't apply any health statement underwriting. So the individual population is going to be taking some of these increases. We've already seen some of those increases hit the marketplace. That'll come up. Small employers, you're going to see some of this certainly come into play. It's been alluded to a little bit with these hours pieces. There's not much we can do about that in the current legislation, where people are going to drop off to be covered because they can get a subsidy. Some of the way the bill's written, would allow an employer to only cover, say, their employee plan or employees, or based on the hours they have, which Tim alluded to, which is a great idea about creating that. You're seeing these 29.5 employee coverage hours, they're dropping off to get on the subsidy side. So I don't have a great answer for what's happening, but at least from most carriers' perspective, you have to keep these pools separate. And the individual policies are going to go up or go down, or however that's going to happen in the small group policies. Some of the bigger changes are going to happen if you have 51 employees or 55 employees, because this law has written into it that, which some of us, or I think all of us, hope that does get moved back, but 1/1/16, if you have 55 employees, you're going to be rated like you're a group of 5. And all the benefits of having more employees is going to go away, and you're going to have to live under some of these rules too. So there are still more changes to come, and there's not much we can do at this point about people dropping off and having this coverage unless some of these legislative pieces happen. And Tom's certainly probably a lot more familiar with what those changes are going to be.
Yeah, you've hit on a couple of important issues. I mean, one, this length of work week thing is a really big deal. I mean, when the Affordable Care Act first kicked in, we saw very large employers like UPS and Home Depot limiting their employees to 28, 29 hours to avoid having to provide coverage. And it is an imposition on the individual to not be able to access coverage and also not have the pay for those extra hours. So I think that one is very highly likely to change. But in a bigger picture, I think talking about what cost shift is at risk from what's today the heavily subsidized or the Medicaid market to the commercial market. I think that's what worries all of our actuaries. The government is a fabulous cost shifter. They underpay providers for Medicaid. They underpay providers for Medicare. One of the things we think will be a benefit of more transparency around pricing is people will actually start to see that outside the actuaries and policy wonks like me who actually look at those numbers and have access to them. That's a big financing issue. Certainly, for us as a commercial carrier, where we don't service Medicaid, we're watching that very carefully. Even though we aren't a Medicaid payer, we're very involved in the Medicaid financing policy at a state level because of that. What we don't want to have happen is people like you essentially writing checks to subsidize the Medicaid program. The Medicaid needs to stand on its own at some point. So there's a lot wrapped up in there. But it's that piece is challenging. And just a word about the expansion of the small group market. That is going to be a game changer for the employers of 51 to 100 employees. They're going from, in Oregon, which is, in the grand scheme of things, Oregon is a tiny market. If you look at the size of states across the country, we have more carriers doing business in Oregon than any other state. The 51 to 100 now is a market where people get to negotiate and get bids and customize benefits. To go from that world to a regulated product where you're rated with much smaller employers with perhaps a more generous benefit than what you might have been buying, or just the frustration of not being able to customize things like wellness programs or particular parts of benefit that you can with a negotiated product. All that is a big reason why the Obama administration, Democrats and Republicans on the Hill, are really interested in pushing back the deadline because they know that it's a political powder keg when it actually happens.
Time for one more question.
Thank you, Warner. I'm Michael Patrick with M&M Realty. Kind of on the other side of the spectrum, I totally agree. Personal responsibility and accountability is the cost driver there. Are there opportunities for closed networks or like-minded people coming together that have a healthy lifestyle, the lower blood pressure, cholesterol, diabetes, and the opportunities for like a concierge doctor to where you have somebody actually managing your health? Do you see any growth opportunities there for individuals that are looking for that? Because that really, I haven't found that marketplace for that I'm aware of. Can you speak to that real quickly? I know we're short of time, but.
Well, the idea of concierge care is continuing to grow. And the model is sort of pay about what you would to a health club and you get easy access to a doc and high service level. But in terms of forming sort of a pool of people who say, I'm going to be the marathon runner and eat right and do all those things, no, we're constrained under the law from doing that because we cannot use underwriting to discriminate against individuals in the individual market. That was one of the big changes in the individual market. That said, is the opportunity there for someone who's very engaged to choose a network product and benefit from the price differential on that it's somewhere in the range of, depending on the arrangement in the carrier, that's going to be a 10 to 20% premium savings for an individual to choose one of those products. And my hunch is that
that people who are engaged are going to tend to gravitate toward those markets as time goes on.
Just real quick, I mean, I think there's an opportunity, and we're seeing that in the marketplace now, for like-minded practitioners and providers to get together. Just an example, Kaiser Permanente is a partner with the Portland Clinic. So they wanted evidence-based protocols, decision support tools for their providers, to help them in their decision-making for evidence-based care. So I think that's a good example, connected by an EMR. But, if you look at what's happening with Zoom Care, they're putting their own kind of concierge network together, kind of corner storefront, if you will. I see Legacy starting their own healthcare. They're a healthcare delivery system. They're starting their own insurance arm. I see it in Samaritan down in Corvallis and Albany. So I think there are some opportunities for providers. And when I say providers, I'm talking physicians as well as hospital systems, to really look and say the marketplace is changing. There is some accountability on our part. How do we do this healthcare transformation? It's kind of the buzzword du jour. So I think that's in the works, and I think that's really where you're going to start seeing the savings, as kind of these leading forefront practitioners getting together and say, what's the best practice out there? And there's lots of things. It's really that focus on wellness prevention, having an electronic medical record, getting that waste and duplication out of the system. I think that's the start to really transforming healthcare.
I wish we could reward positive consequences. And it's unfortunate that when the bill was written, and as Tom stated correctly, we focus on the wrong part of discrimination. Because I think that there's a lot that we can do just by being more involved, and kind of some of the things that we talked about with just our own personal ownership. And why not take a look at the single mom who quit smoking and said, here you go, I'm going to reward you for that consequence. So to me, I think that's going to have to be a grassroots error, because that's just, we're so negatively focused on this, and there are a lot of really good things that the Affordable Care Act is bringing. It's bringing about this discussion. It's bringing the providers, the insurance carriers, the small business, the those that care all to the table at once. Instead, we used to just sit there and blame fingers back and forth, or at least I used to do that a lot with Jeff, and I still do. But I mean, this is where I think that where we can take to our elected officials, to those in the room, to those that represent this state, to those that represent us in Washington, that I think that's the voice that needs to be heard, because I think that there is time, and I think that there's some energy around this, that we could get some more positive things from this. And why not? Why not reward people for good behavior? So not to say that we can't get it done, but I think we got a big road to hoe to get there. And I think that if more of us that kind of stand up, that just kind of say that we are fed up with some of this stuff, our voices are now starting to be heard. So I think that's a good question, and thanks for bringing that up.
Gentlemen, thank you very much for a stimulating session. I think you have brought to the forefront several enlightening issues that have made us think a little more about the health care in our country right now. So you have been very enlightening today and very educational, and I want to thank the folks here who have attended. I want to thank my Government Affairs Committee under Warren's leadership for providing this forum today for this discussion. I want to thank in particular again our sponsors for today, the Portland General Electric, Riverview Community Bank, and the Gresham Barlow School District. Don't forget, when you see those folks, tell them thank you for Government Affairs forums. On your tables, we have left for you an evaluation form. We would appreciate it if you would fill those out now before you leave. Those will be your ticket to exit and go back to work. That's for you, Mike. Reform good behavior. But just leave them on the table. We will collect them afterwards. I'd like to remind you that March forum next month is scheduled to be a mayor's forum with Mayor Doug Doust of Troutdale, Mayor Patricia Smith of Wood Village, and Mayor Ted Tosterud of Fairview. And Mayor Ted is here today. He's been here the last couple of times I have been here, so he's observing the format for next month, Ted. The following month, our own Gresham Mayor Shane Bemis will be our guest at that Government Affairs Forum. I would remind you that online registration for the next forum is already available to you, and if you have internet access, you may register right now before you leave for next month's forum. If you did not bring cash with you, Jesse is at the back there by the exit waiting for your credit card. But we will be happy to take your pre-registrations today as you leave. So look forward to those next forums coming up. Thank you again for attending, and thank you, panel members.